I thought I'd start by trying to make it a bit interactive on Saturday morning, and have a think about what actually multiple endocrine neoplasia is. So help me out. Endocrine. What is endocrinology? What is it that encompasses? Yeah, so endocrinology is a study of hormones, and hormones are the chemical messengers in the body, within the body, that give signals from a gland to most of the other cells in the body. And endocrine is sort of the secretion of those hormones within. So the glands that secrete hormones are called the endocrine glands. How about neoplasia?
New growth?
Yeah, so new growth, and I think I'd qualify that with probably saying new abnormal growth, so growth that is not under the normal control as it should be, and that splits into two types of abnormal growth. We call benign growth, so non-cancerous growth, and then cancer, and that sort of neoplasia encompasses both of those, and sometimes it's not straightforward to tell the difference between something that is non-cancerous, benign, and cancerous, and that's one of the difficulties that is faced day in and day out, I guess, by clinicians when one talks about the sort of generic word tumour. It can encompass both types of growth. So the condition multiple endocrine neoplasia was first described as an association when people noticed that two or more of these unusual or rare tumours were popping up in the same person. So the syndromes were described before any understanding about the underlying causes were really worked out. And you're going to be hearing a lot more detail later on about what we know now about some of the molecular type mechanisms underlying it. But I think Neil, who's giving one of the talks later, won't mind me saying that there's still probably the largest amount of work is still to be done in terms of our understanding, but it's moved on certainly since the first descriptions. So next door, MEN1 is being discussed, which is only similar in terms of the fact that it's, for some reason, seems to target and affect the endocrine glands, and we're going to talk about MEN2. Okay, sorry, more questions. So we now know that these conditions are genetic conditions. So again, what are genes? What do we mean when we call it, say, a gene?
So what makes you you?
Yeah. Essentially, that's I like that answer. It makes us, doesn't it? Or makes humans and flies, essentially. So the genes are the specific bits of our DNA within each cell that code, in simple terms, for protein. So each gene codes for one or more proteins, and it used to be thought by ourselves as humans that we're very complex and we had lots and lots, hundreds of thousands of these genes, because we're really clever. But in fact, the more we look into it, the more we find that there aren't as many as we thought. So what does anyone know what sort of current guesstimate there is of how many genes?
20,000?
Yeah, 20,000. Exactly. That's probably more or less where the land lies. Is that right, Neil? Is that fair enough?
The splicing is very important.
Yeah. So that alludes to the fact that each gene probably can make lots of different proteins, and the control over each gene is such that as an organism gets more complex, there probably is more regulation over each of those genes to allow us to evolve and diversify. So a mutation, that's another word that's thrown around. Lots of these words I'll try not to flip back into my first language of medical lingo, but a mutation is often thrown around. What's a mutation?
Kind of a mistake.
Yeah, I think that's exactly right. So a mistake, most of the mistakes that happen within our DNA and genes go unnoticed because most of our DNA doesn't seem to have an obvious role. It doesn't code for a protein. But when a mistake happens somewhere along the line that affects the outcome of what that gene is making and causes a problem, then it's called a mutation. So lots of them don't cause an obvious problem, but when it does, then I think that's probably what I'd say is a mutation. So what's MEN2? Well, this was, it's sometimes called Sippel syndrome because that was the first person that described it back in 1961. It's thought to affect about 1 in 40,000 people, actually, and there are 3 main endocrine glands, as you know, that are involved. And what I want to do is just go through each of those glands, what they normally do, what the hormones are that they normally make, and then we'll talk a little bit about what the problem is that can develop within MEN2, a little bit touching on the specific genetics behind it, and then having a think about the sort of treatments that one would want to be considering, and perhaps what sort of monitoring and screening one should be having with each of these. So the thyroid is the first gland that's affected, and that's usually in MEN2 for at least 95 to 100% of people is affected, and one develops medullary thyroid cancer within the thyroid gland, and is usually the first problem that appears unless someone has the diagnosis made at birth before anything develops. The adrenal gland we'll talk about will only be affected in about 40% of people, and the parathyroids, which we'll talk about, may be only in about 25%, and all of those numbers vary depending on who you look at, what you look at, and also the actual genetic underlying problem. So the thyroid gland, where is it? Well, the clue's on the picture. So the thyroid gland sits in our neck, just below, or the join between the 2 lobes of the thyroid is normally just below one's Adam's apple in men, and it sits in the neck with a lobe on each side of the neck. What hormones does the thyroid gland make? So thyroxine is the main hormone that it makes, and that's the inactive thyroid hormone, which is made into triiodylylthyrin. Oh, I got my tongue tied. T3, which is the active hormone, most of which is made within the cells of the body. Having the thyroid gland secretes thyroxine, and then the cells in the body remove an iodine from it, and the active hormone is triiodylthyrin. What does thyroxine do? One word answer. Yeah, metabolism. So it's sort of your hormone of metabolism. So it has an effect on every cell in the body, and it has wide-ranging effects. But really, if one wants to put it down to one word, then it's sort of the hormone that can control one's metabolism, one's sort of rate of turnover, or one's speed, if you like. The thyroid actually has 2 types of cell, and the cell that makes the thyroid hormone are the follicular cells of the thyroid, and makes up the bulk of the thyroid gland. But scattered within all of our tissues, there are cells that we call neuroendocrine cells, so other cells, and within the thyroid gland there are these neuroendocrine cells, which are called the parafollicular C cells, and that's what we're going to be thinking about when one talks about medullary thyroid cancer. So medullary thyroid cancer is a cancer that develops from these scattered C cells within the thyroid gland. And what happens initially in the condition of MEN2 is that you get an overgrowth of these cells, not necessarily that abnormal overgrowth that we talked about. So it's something called hyperplasia, where there's an expansion of the cells and the cell number, but still in a controlled way, as opposed to a neoplasia type response where things go out of control. So one initially gets an expansion of the cells, and then on the background of that, one can get a neoplasia, which is a cancer formation in this sense, where one gets the problem of medullary thyroid cancer. Normally in people, the C cells do produce another hormone, which is called calcitonin. And in animals other than humans, that has a role in terms of bone metabolism and bone turnover. And it's not well defined what calcitonin does in humans, if anything. So the fact that these cells make calcitonin is important for 2 reasons, I guess, when one's talking about medullary thyroid cancer. And the first one is that most of the medullary thyroid cancer still produce the hormone calcitonin, and that allows one to measure this hormone in the bloodstream and use it as a marker of what's happening with the cancer. And it's not the most accurate marker, but it would give you an idea, if it's undetectable, that there shouldn't be any C cells in the body. If it's steady over time, it would suggest that the cancer's steady over time. And if it's changing and going up quickly, it would suggest the cancer's on the move. And likewise, if you're giving some treatment and it's going down nicely, it would suggest that the cancer's responding to that treatment. It also makes another protein called CEA, which can also be useful as one of these tumour markers when one's following the thyroid cancer. It's also important because at very high levels, it can cause symptoms. So symptoms of flushing and diarrhea, and those might need treatment separately to everything else if that's a problem. Typically, the symptoms that a medullary thyroid cancer would cause, or what might be the first problem if someone's not known before to have MEN2, would be a lump in the neck or lumps in the neck. And as I said, it can also be, can cause symptoms if the calcitonin is very high. So medullary thyroid cancer is a cancer, which means that it can spread from outside the thyroid gland. And where can it go is the next. Yeah, so did you say? Lungs, yeah, so in fact it goes 3 different ways, if you like. It can go locally, so it can cause problems around the thyroid gland in the neck. And then it can spread by both the lymph system throughout the body and by the blood as well. So it quite commonly can go to the bones, the lungs, the liver, and to the nodes in the neck. So all of that's very important when one's trying to work out where it is and how far it's gone. So changing gland and moving down the body. The adrenal glands, again, where are they? Well, the clue's in the picture there. They're small glands. We each have 2 of them, and they sit above the kidneys. What hormones do our adrenal glands make?
Adrenaline.
Yeah, so they're called after the fact that they make adrenaline. And what kind of hormone's adrenaline? It makes, so yeah, but go back to the adrenaline. What do we call that? The fight and flight hormones. So those are the sort of the hormones of one of the stress hormones, the hormones that go up if we're giving a talk in front of an audience or we've got an exam or whatever. And then, as you said, cortisol is the other hormone that we're going to talk about a bit later on in the second talk. And the adrenal glands are made up of 2 very distinct components. There's the middle bit, which is called the medulla. And then around that is a sort of rim of completely different cells called the cortex. And the outer bit of the adrenal gland makes the hormone cortisol and a few other hormones that we'll talk about later. And the inner bit is what makes the adrenaline. So pheochromocytoma. There's a standing joke at medical school that if in your exams you say the word pheochromocytoma, you fail your exams because it's such a rare tumour that one shouldn't be coming up with these rare diagnoses at medical school. So that's why the name's so long. And it is normally a rare type of tumour. Medullary thyroid cancer is also a rare tumour. Thyroid cancer is a rare diagnosis, but there are 2 more common types of thyroid cancer called papillary cancer and follicular cancer, and medullary thyroid cancer comes down that list by quite a long way. So pheochromocytomas are similarly very rare, and they are tumours that grow within the central bit of the adrenal gland, within the adrenal medulla. Outside MEN2, sometimes those tumours can also be cancerous, but in MEN2 they tend not to be. And outside MEN2, those tumours can also pop up in many other parts of the body, sort of between the base of your skull and right down to your pelvis. But again, in MEN2, they almost universally tend to grow within the adrenal glands themselves. So pheochromocytomas make hormones as well, and that is typically, particularly in MEN2, that can typically be, they can still make adrenaline, but they often make the hormone that comes before adrenaline, which is called noradrenaline, which has some similar type effects in terms of your fight and flight response. Because what we're going to talk about next is the fact that this is a genetic problem and an underlying gene problem, which means that both one's adrenal medullas are at risk of getting these. Sometimes both of the glands can be affected. The symptoms are symptoms that we've all had and can all get for lots of different reasons. And those, if you like, to put simply, when we're scared, so you can get, your blood pressure goes up, your heart rate goes up, you get palpitations, sweaty, your your eyes look like a rabbit in the headlights, and one can have symptoms of panic attacks and sometimes dizziness. So all of those symptoms we get from time to time, but can be caused out of the blue if one's got a pheochromocytoma. And the way that they tend to produce the hormones is not regulated, and that's the big difference between the hormone production from a pheochromocytoma and what one would normally make. The levels are higher, but also it can come in surges, which can cause the problems and the medical complications. Okay, changing gland again. So the parathyroid glands, they sit behind the thyroid. Most people probably have 4 of them, and they're little glands that sit behind sort of the top bits of the thyroid and the bottom bits of the thyroid, and most people will have 4. In fact, you can have many more than 4 because the way that they develop is moving down the neck, and little cells can be left behind, scattered around the neck, and they can sometimes overshoot and come down into the chest. So it's not as straightforward as the thyroid gland, which tends to be in one place. And people have been known to have as many as 50 of these parathyroid glands. So the difficulty with treating them or finding them when they go wrong is the fact that they can be well spread, but they normally remain quite small. What hormone do parathyroid glands make? Parathyroid hormone, yeah. The clues in the name, like the picture. And what does parathyroid hormone do? Yeah, okay. Oh, it's too easy, yeah. So, yeah. So, good. Just checking that everyone's awake and can read. So parathyroid hormone is important in maintaining a normal level of calcium in the blood in the body, and it does that in 3 main ways. The first is that it controls the amount of calcium going into and out of your bone, and if you've got too much of it, basically it steals the calcium from one's bone. It also works by stopping you from peeing out all the calcium, so it grabs back the calcium that you're losing in the kidneys. And then it also helps you regulate the amount of calcium you absorb, and it does that by regulating the amount of vitamin D we produce, and vitamin D is important for absorbing calcium from the bowel. And vitamin D is something we can maybe talk about in the questions and answers, because except for today, we don't get very much vitamin D because it's from sunlight. In fact, and you're all stuck in here, so you're not getting any vitamin D anyway. But in the UK, if you measure vitamin D in all of our bloods, it's extremely low unless you're taking some cheating supplements, because the sunlight we get is not sufficient to get a good level. And vitamin D is important for maintaining your bone health and your muscle health, and it probably has important effects that in terms of one's immune system, in terms of one's heart, in terms of cancer risk, in terms of diabetes risk. So it's something that's worth considering in the context of MEN2, I think, although there's not good evidence about what role it may or may not have. So if things go wrong with the parathyroids, in many ways it's really quite difficult, particularly if it's in the context of something, a condition like MEN2. So the condition is called primary hyperparathyroidism, which just means an overgrowth of the parathyroid glands due to a problem within the glands themselves. You might hear the term used of secondary and tertiary hyperparathyroidism if one's reading something about it. And having talked about a loss of vitamin D, if we're all low in vitamin D because we don't get enough sunlight, what that does is it encourages your parathyroid glands to be overactive, so that you try and make up for your inability to absorb the calcium from the gut. You make up for that by taking the calcium from your bones and holding back more calcium in the kidneys. So that's called secondary hyperparathyroidism, or it's an example of it. It's your parathyroid hormone levels are high, secondary to the fact that we don't get enough sunlight, essentially. And so just having a high level of the hormone does not mean one has got primary hyperparathyroidism. One's got to have a normal vitamin D in order to make that diagnosis. The difficulty with primary hyperparathyroidism comes in the fact that we have more than one gland, and they're all small, and in MEN2, it can be the case that all of the glands are affected, or it can be the case that one of the glands is affected. And it may be that that's controversial. It may be that one gland is affected more than the other one, so it's the dominant cause of the problem. And what that means is if there's a problem with it, it's quite hard to know exactly what to do because, and we'll talk about that a little bit going forward. If we've got a high calcium, again, the symptoms that causes are mainly related to the fact that your high calcium means that you are peeing out more calcium, and with that calcium you drag out the water as well. So it means that one's walking round in a permanent state of dehydration, if you like, which causes symptoms such as having to get up in the night to pee, being permanently thirsty, but also other less specific symptoms that we might all have from time to time, like feeling generally tired or having some constipation or some abdominal pain. And again, it can be quite hard to work out whether the symptoms that one might have is related to a slightly high calcium or is just related to life. In terms of the effects that it can cause, more medically speaking, not surprisingly, if one has a high level for a long time, one can see that one loses calcium from the bone so that you end up with some bone thinning or tendency towards osteoporosis. And similarly, if you're passing lots and lots of calcium through the kidneys, you can end up getting deposition of that calcium in the kidneys and either renal stones or something called nephrocalcinosis. And ultimately that can cause damage to the kidneys and kidney failure. So those are the sort of things one needs to be thinking about when one thinks about a slightly high calcium. Other problems occasionally mentioned when one's talking about MEN2 include Hirschsprung's disease, which is a problem that children can sometimes get, often appearing with some constipation or sometimes failure to put on weight. It's only very rarely linked with MEN2, and that's to do with the underlying way the genes work and the fact that it's a slightly different process. And similarly, cutaneous lichen amyloidosis is not something I've ever seen somebody have, but is something that can occur with MEN2. And you'll have heard of the fact that some of the changes in the gene only seem to give the medullary thyroid cancer without the other bits. So it's less of the multiple, although I think if one carries one of those changes that is called familial medullary thyroid cancer, it just probably means the risk of the other things is much, much lower, but not absent, I would have thought. So a little bit about the genes, I guess, as that's what we now understand to be behind the cause of MEN2. And you'll hear a lot more about this later, so I'm not going to go into a lot of detail, but I guess what you will hear later is that although we know this is the gene that causes it, we've still got a lot to learn about the exact mechanism of why it only affects these particular parts of the body and what insights it can give us into how we might treat the problems as they come up or before they come up. So the RET gene, it's one of our 20,000 genes, and it's a gene that's called a proto-oncogene. And that's a term given to a gene that, if it undergoes a mistake, a mutation, can lead to the formation of cancer. So most of the proto-oncogenes are normally genes that are responsible for having some control over the normal growth of the cells. And when that goes wrong in a way that activates, so it switches on that gene, it becomes from a proto-oncogene to an oncogene, to a gene that can cause tumour formation and cancer. And this particular gene makes a protein that's called a tyrosine kinase receptor. So I think you'll see later on the fact that, or we've all seen before, the fact that this is a receptor that sits on the outer surface of the cell. And within the cell, there's this enzyme called tyrosine kinase, which is controlling things. And on the outside is a receptor that acts as that in normality will act as the switch when something comes along and attaches to the receptor. But if there's a change that causes this to become an oncogene, that means that switch is permanently on and has lost its control mechanism. So it's causing cellular changes in a permanent 24/7 way. How is it found, or when is it thought about? So if in my endocrinology clinic someone has a thyroid operation, and within that you see the fact that there's an overgrowth of the C cells. So the C cell hyperplasia that we mentioned earlier on, that would be one reason for thinking about whether there's an underlying genetic change. So whenever one finds that all parts of the thyroid are involved, that's the sort of thing that would make you worry that there's an underlying predisposition to form the problems. Most people that have this rare diagnosis of medullary thyroid cancer we would think carefully about whether or not they should have the genetic check for a RET gene. There are lots of clues sometimes, so people, as you know, with MEN2 will tend to get the medullary thyroid cancer at a younger age. So if one's getting it at the age of 70, it's very unlikely to be underlying caused by a gene change. And you can get clues from the normal thyroid tissue. If that looks completely normal and there's no changes in the C cells, that would also make it very unlikely to be caused. But most people with medullary thyroid cancer will probably end up having the gene check. And then probably the main group of people that obviously have the check are family members who have, where one member of the family has been found to have the gene change. And we know the gene is passed on in a way that's called autosomal dominant, and what that means is that each of one's children has a 50% chance of inheriting the problem. So that would equally well mean that one's mother or father, if you're the person that's had it found, would have a 50% chance of having had it, and any direct relative would have the 50% chance of finding the same gene. We'll talk a little bit later when we talk about treatment about the fact that we now understand that the specific mistake, the specific mutation that causes the MEN2 also allows us to predict some aspects of what might be coming. And that's in terms of the type and aggressiveness and the age of onset of the thyroid cancer, as well as whether there's a risk of some of the other problems like the hyperparathyroidism or the pheochromocytoma. So we're getting, I think, better insights into what we call the genotype-phenotype correlation. So the genotype is what the gene change is, and the phenotype is how that reveals itself, what it shows itself as. And that can help, particularly when it comes to thinking about children. So a little bit about treatment and touching on treatment. Clearly the best treatment is prevention, and by prevention that's possible if one's having children and one knows exactly what the gene change is, then it's easy now to get the genetic test for a child as they're born and work out whether or not they carry that gene change. And then having their thyroid removed at a particular time, and the timing of that is crucial and will depend on what we've talked about, which is the type of gene change and what that risk is of the age of onset, essentially. So a child will be offered a thyroid operation from birth in one case up to probably no later than the age of 10 for most children. For an adult with medullary thyroid cancer, things are much more difficult to plan, and I'm not going to go into the details here because that's the subject of a completely separate talk, but the sort of decisions that need to be had are what kind of surgery, how extensive that surgery would be, and what one's aims of the surgery are, and all of those really important questions before one dives in to just try and remove whatever one can, because a lot of the time one could end up doing more harm by trying to remove something than by actually just being more conservative and thinking about other options at the same time. So if the cancer's outside the thyroid gland, then other options that will be talked about include radiotherapy, sometimes the ability to use what are called radionuclide therapy, so something that's specifically targeted and taken up by some medullary thyroid cancers, unfortunately not the majority of them, just some of them. And then you would have heard at some of these previous days and about some of the new chemotherapy drugs that are available, that a whole group of drugs called tyrosine kinase inhibitors, which not surprisingly act on the tyrosine kinase receptor and can be quite useful as potential treatments to try and hold back the medullary thyroid cancer.
So these are for secondaries, are they?
So this is when, yes, so things to consider when, if someone's coming up for the first time and the cancer's already spread, exactly. But all of those treatments are to hold the cancer back. They're not curative, and therefore I think the key thing is making sure that the thyroid is removed before the chance of the cancer has to develop. Just this slide is to remind me to just say that certainly in the American Thyroid Association and the other American networks, the gene changes, and there's only a few of them here, are put into different categories now. Sorry, it doesn't project very well. In terms of what the risk level is, whether it's a high risk of medullary thyroid cancer, by which they don't mean very high, and so the age of suggested thyroid removal might be between the age of 5 or 10. If the risk is greater, it may be before the age of 5, and then if it's very high, it's sort of within the first 6 months of life. So one can help plan when to operate, depending on that, the gene change. So, pheochromocytoma, one would have thought the treatment of that would be relatively easy, but I think that's also fraught with some difficulties because fortunately in MEN2 this is normally a benign tumour, so it's a non-cancerous tumour, but the difficulty is it can affect both glands, and depending on what age one is, if one gets it, one might want to think, and what size it is when it's first found, one might want to think about watching and waiting for a little while. If one's got one's GCSEs coming up, you don't want to be having an operation, and if it's relatively small and not making too much hormone, it would be very reasonable to wait and time things according to the right time in life, as it were. If it affects both glands, as we're going to be talking about later, then the problem comes the fact that one needs to take extra medication and extra treatment to replace the function of those endocrine glands. If the hormones are in excess, and before one has surgery, one needs to definitely put a block on the effects of those hormones so that you're not walking around in permanent fight and flight mode. And we do that with drugs called alpha blockers. That will be things like phenoxybenzamine and doxazocin, and usually as well with drugs called beta blockers like propranolol. And that will keep things safe and control the symptoms and hopefully control any surges of the hormone whilst one's preparing for surgery. And that would also obviously make the surgery much safer as it comes to handling these tumours. And then the parathyroids are also, as I alluded to, not straightforward and not easy to treat in my view. And the sort of questions that I would want to be asking if there's a problem is, if the calcium is high, is what problems is it causing, if any? Is it causing symptoms? Is it causing damage to the bones? Is the calcium in the urine very high? Is this going to cause a problem if we don't just watch and wait? The second question, if one thinks one needs to do something about it, is trying to work out which one of those 4 glands is involved, or whether all of them are involved. If all of them are involved, I would argue that if one removes all of them, one's not necessarily in a better position than you were in the beginning, because you've lost that control mechanism. You've lost the ability of the parathyroid hormone to regulate your bones and regulate the calcium in the urine. So it needs some careful discussion and thought. One of the relatively recent advances is a tablet called cinacalcet that can reduce the level of parathyroid hormone in the blood and can lower the calcium, and that's I think a particularly useful holding measure, if you like, in both MEN1 and MEN2 potentially. Oh, it's jumped on ahead. It's obviously I'm running slow. Just to sort of finish off the final couple of slides before we can ask any questions is just thinking about the monitoring and screening of the condition. Some people will be seen in a sort of dedicated MEN clinic. Some people will be seen by, hopefully, the same team of people, and a lot of what might be seen in the MEN clinic will be happening behind the scenes, as it were. So involved in the discussions of any genetic condition will be lots and lots of different people, and of course, as I'm an endocrinologist, I put endocrinologists at the top, but by no means are we the most important. You're the most important person, and probably second to that is, in most places, is the the first port of call at the hospital, which would be the clinical nurse specialist perhaps for most people, so that one's feeling that one can get in touch if there's a problem, so that there's the monitoring, which might be routine, but the ability to get in touch with the hospital if one thinks there's something new or something worrying that's cropping up. But behind the scenes will also obviously be the geneticists, and some geneticists might actually have their own clinics where they're looking after the condition. Oncologists, surgeons, radiologists. I've put down psychologists as if that was something that is available on the NHS. I think that's a wish, but certainly through organisations like MEN2, then there is a little bit of access to what's not available on the NHS in terms of that, and wouldn't it be nice if there was a way of getting that ingrained into the system?